Hi, I'm Tracy. I'm one of the advanced nurse practitioners from Birmingham Children's Hospital. And today I'm just going to give you a quick overview of external ventricular drains, or the EVD, why we use it, how we use it, some really key concepts that hopefully are going to keep you safe at the bedside when you're managing patients with an EVD. So an EVD is a temporary CSF drainage system, essentially, that is either going to be required in patients because you want to reduce the ICP, and you can use that as a strategy if the EVD is in situ to get your ICP down quickly by draining some CSF, or because you want to divert CSF flow post-operatively, or because of significant post-operative bleeding. So essentially patients that may have traumatic brain injury, or have had a tumour excised, or have hydrocephalus, for example. So the flowchart here shows us the production of CSF, so we can see its production in the choroid plexus, and then it drains through the lateral ventricles, ending in the spinal cord, surrounding the spinal cord to provide some buoyancy and lubrication. And the EVD is a system that essentially is going to rely upon that pathway, but is very dependent on the ventricular pressure to either drain or have its CSF drainage impeded by pressure. So if the EVD pressure is greater than the ventricular pressure, then we're not going to get any CSF flow from that ventricle. However, if the EVD pressure is lower than the pressure in the ventricular system, then CSF drainage will be encouraged and it will flow through the EVD system. And so the drainage is therefore dependent on gravity, and this is a really important factor when thinking about how the EVD needs to be positioned. The whole concept of the EVD is obviously to drain CSF. And we need to drain CSF because we've placed this because CSF either can't be drained, or it's been overproduced, or it's blocked. And therefore, without allowing the CSF to come out, the ICP is going to go up. So everything that we need to do when a child has an EVD in is to take measures to ensure that CSF flow is always constant through that EVD, and that nothing blocks the EVD, slows down the CSF drainage, that we are then going to revert back to having raised ICP within the child's brain. So the first thing we need to do is make sure that the position is always right. So because we've said that the CSF flow is dependent upon gravity, the position's really important. So the EVD is always levelled with the foramen magnum, which essentially what we do at the bedside is we level that with the tragus of your ear. And the position you can see on this picture here, it doesn't matter what EVD system that you use, they'll all have this levelling arrow, which will go up or down, and I will show you this on the main system at the end, with whatever centimetre of water the surgeon has decided intraoperatively is the right centimetre of water against gravity to encourage the amount of CSF drainage that they want. Most of the time it is set at around 10. It often changes throughout the child's stay depending on how much CSF is draining through the EVD system and whether they want to slow that down or they want to encourage some more drainage. But that is always something that's decided by the neurosurgeon who's performed the operation and is making those clinical decisions upon how much CSF he wants to drain. So once this has been levelled, and this arrow, which equates to the transducer system, again, which I'll show you at the end, is always level with the tragus of the ear, you'll get a predetermined constant amount of CSF drainage that roughly comes out each hour. And this needs to be monitored and documented. But there are things that's going to change, like we've talked about the flow of CSF throughout this system. And one of those could be that we have raised or lowered the EVD above the levelling with the tragus of the ear. So essentially, if we raise this EVD much higher than where it should be set at, we're going to increase gravity and discourage CSF flow. And conversely, if we take the EVD system off and we lower it below the level of the foramen magnum, we're going to make it much easier for CSF to flow into that EVD system, and potentially we could encourage a big outflow of CSF into the EVD, which wouldn't be great because it carries the risk of collapsing the ventricles if we have encouraged too much acute loss of CSF. However, lowering the EVD to the floor is a good way of troubleshooting your system if you think that there is a blocked EVD. So the thing to always remember is that the lower the EVD system, the greater the CSF drainage is going to be because you've got less gravity. So at Birmingham, all of our patients will go onto an EVD care pathway. So once they're admitted from theatre, after the EVD has been inserted, and that's just because our EVDs are inserted in theatre in this hospital, they will have a pathway completed. So on admission, we fill in the details, the most important things being to note from the surgeon what level they want the EVD set at. And that's really important because if the level isn't set where they want, or we haven't documented that and something happens and the level gets changed or moved, and I will show you on the system shortly how easy it is for that to move around, we actually could significantly be changing the amount of CSF drainage that we're getting through this EVD system. And the worst case scenario is that we're lowering the CSF drainage, we're not getting enough out that we want, and we're potentially raising the intracranial pressure. This is obviously if you want ICP monitoring on the system, which we can do. I'm not going to go through that today, but I will show you where that's done. The important thing to remember is that monitoring ICP through an EVD is not the gold standard. The gold standard would obviously be an intracranial bolt. And again, when we look at the system, because it's only set up using two-way taps, you can only either monitor ICP or you can drain the EVD. And that's really important to remember, because if you're monitoring the ICP, you're not going to have any CSF drainage through this system. And if you forget to open it back to drain again and just monitor the ICP, no CSF will come out and the ICP will rise. If the EVD level changes, and again, this should only be prescribed by a neurosurgeon because they've made a clinical decision that they want to change that level, they should re-prescribe that here. So time, date, name, so that the last person that's doing their daily checks can always check that the EVD is in the right place. And then when we remove the item here, and we'll bring up the full care pathway just to show you that at the end. So the EVD needs to be documented and observed continuously at the bedside by the nurses, and they will document obviously how much drains every hour. And there isn't really a set amount that you should expect to drain. It's more about a pattern. And remember that most EVDs are being put in and they will have huge amounts of drainage at the start. So it might be that they've had a post-operative bleed or that they've first gone in. And because the ICP is so high when they initially go in, then the CSF drainage is going to be much higher. And gradually over time, that will start to tail off. So things in the actual volume that are important to know are if suddenly, obviously, the CSF drainage increases. But remember, the patient moving around in bed, because the level with the tragus may change slightly, it could encourage some more CSF flow. So you need to take that into account. But the most important thing to remember is, has the CSF drainage stopped or has the CSF drainage tailed off? And if that happens, you need to assume that your EVD for some reason might be blocking, and then you need to take the appropriate steps to troubleshoot that management, which we'll go on to on the next slide. The other things that you're going to observe every hour, and that the nurses are definitely going to highlight, is if the drainage of CSF looks an abnormal colour. So we should expect nice, clean CSF to look like a good champagne. And if any blood is documented, it might just be that there's blood staining, it might be that there's fresh or frank blood, or it might be that the CSF starts to look cloudy or get some debris in it, which is a sign of infection. The nurses at the bedside are definitely going to escalate that to you, and that will then need to be escalated through to the neurosurgeon for ongoing management. Blood can always be a tricky one because there's often fresh blood in the EVD when the patient first comes back post-operatively. And what I would say again is just that the whole point of that continuous monitoring of the EVD system is it's going to give you a really good picture of what's happening with it. What I would expect when they first come back is that they have fresh blood, that within a few hours, hopefully that starts to tail off into blood-stained CSF, and then eventually that starts to clear towards a more normal looking pristine CSF. But if at this point, once the blood staining is cleared, you suddenly get a rebleed, or you start to see blood that you didn't have before, that's definitely then something that needs to be escalated, because something new has changed within the pattern and the colour of the CSF that you're draining. So it should drain roughly a regular amount. Doesn't matter what the volume is, as long as it's not zero. But if it starts to reduce, you need to determine why. Because the tricky thing about an EVD is that eventually we expect the drainage to tail off. But drainage tailing off in terms of absolute number of volume that comes out each hour could be that the EVD is blocked. And obviously a blocked EVD is a neurosurgical emergency, because if your EVD is not draining, there's no CSF coming out, your ICP is going to go up. And if you don't treat an ICP, eventually that could lead to the worst case scenario of coning. So remember that a blocked EVD is a neurosurgical emergency. So any suspicion of a blocked EVD, because it's under draining or it's had a zero drainage, any hour that the nurse documents a zero drainage, you need to escalate and go through some troubleshooting measures to determine if you think that EVD is blocked, and therefore does it require immediate escalation to a neurosurgeon. It should really only be a neurosurgeon that can determine whether or not they're happy that this drainage is because the drain is naturally tailing off, or because it's blocked. And so it is really important to have some consistent guidelines and have some consistent teaching it, and build a relationship that's very clear with the neurosurgeons as to what's going to be expected in the critical care environment and what the nurses are going to escalate. Because actually, if the drain is just naturally tailing off, as long as the neurosurgeon can come round and have that discussion with you and document in the notes that they're happy with that this drain will eventually not drain, expect low levels of drainage, expect some hours when it's not going to drain, and the nurse will document a zero. And then actually we can clearly have that documented, and they won't be called every time the nurse gets a zero drainage on the observation chart and wants to escalate because we think that the drain's blocked. And that's really about establishing pathways with your neurosurgeons and getting them involved within clinical practice meetings where you're creating and signing off these documents to kind of iron out some of the difficulties which you can face where there's, you know, competing teams. And I think historically it's always been quite difficult that some of the problems that we had initially when before this care pathway was developed was that different areas within the hospital that had children with EVDs would escalate very differently. They would often forget that there's one neurosurgeon and they're tied up in theatre all day, so they can't immediately come. And the neurosurgeons would come from very different hospitals that all had totally different practices. They worked within our trust where different wards and PICU had different practices, and actually it did make it quite difficult for them to know what to do, and therefore didn't give us the response that we expected, and can create quite a bit of tension. So I think just being open and designing these guidelines together has been really, really integral for us to getting patient care that have EVDs right. Because I suppose what I want you to remember is that it's an extra corporeal circuit in the ventricle of a patient's brain. And it's a really high risk device, because if we get this wrong and it doesn't drain and it blocks, we're going to raise the ICP. We don't want to introduce infection and give you a meningitis. We certainly don't want to encourage a massive amount of CSF drainage that collapses down the ventricle. What we want to do is to make sure that you've got something in that enables good CSF flow, that keeps your ICP down and keeps you safe and enables a good recovery. And again, it will be very different between different trusts, but certainly at Birmingham, we don't use EVDs that frequently. And so it really makes the use of the device much higher risk, because it's not something that's commonplace on intensive care. And so when a patient arrives from theatre with one, I might be faced with nurses and registrars potentially that haven't seen or used an EVD in 6 to 12 months. And so having this consistency in your approach is really, really important. So the other rule that I really, really want you to remember is that an EVD must always be open to drain. So if you remember the concept of open to drain, that will get you through a lot on the critical care unit, keeping you safe with these EVDs. And the reason I say that is, again, because the EVD is built on, no matter what system you have, it has a two-way tap. And so if it's turned, it can only drain CSF, so the CSF flow will come through the tap here into the drainage chamber, or if the tap is turned, it will be off to drain and open to where you connect to the ICP. So if this tap is left off in the opposite direction, no matter how much CSF is trying to come out these ventricles, it's off to the drainage chamber, and therefore CSF won't be able to flow, and we will increase the ICP. So a closed drain is a blocked drain. But a blocked drain can be created by mostly human error. And that's why we created the care pathway, to try and eliminate and troubleshoot very, very quickly the human error that leads to a blocked drain. And the number one being this tap. The second probably being other taps on the system. And the third being that the tubing's just got a bit kinked or it's folded over. And most of them we can resolve straight away. We can get the EVD draining again, and we don't need to escalate to the neurosurgeon. And that's, again, has been really important in not almost overloading neurosurgeons with tons and tons and tons of calls that then they come and they feel that they didn't need to come for because we could have fixed them. And so having this system in place has given a lot more confidence to the bedside staff to be able to troubleshoot most of these problems and keep the EVDs draining. So again, if it starts to drain less, you need to address straight away, okay? So if your EVD, for example, is draining a consistent amount of anything between 5 and 10 mils an hour, and all of a sudden it drains 1 mil, I would expect you to go through a process of troubleshooting just to make sure that that drains okay. And most certainly, if you ever document a 0 on the observation chart and there's no drainage or 0 drainage, you should assume your EVD is blocked, troubleshoot it, and escalate if you get to the end of that pathway and you think that that EVD is blocked. So I'm just going to quickly bring up the pathway. So this is the EVD care pathway. We've been through the first section. So this is if we suspect a blocked drain, and it's essentially a nice flow chart that will guide you through the process of checking for a blocked drain. So you've documented a 0 or there's a 1 on the chart. You think, oh, I wonder if this drain is blocked. And the first thing that you want to do is to check the actual insertion site on the child to make sure it's still in, to make sure that the connection hasn't loosened. So into the patient, the first little connection is like a lower lock tap. And so sometimes that can come loose. And what you need to remember is that most of our children are lying flat in bed. So if the CSF leaks from the actual insertion site, it's just going to get hidden on the pillow behind them. So actually having a good look and feeling the pillow is really useful to see whether actually the CSF has leaked out of the system and that's why you haven't got any drainage. But if it's not leaking, what you want to do is to have a look for any clamps, any obstructions, any clots or any kinks in the circuit. And if you find any of them, you need to alleviate that. So obviously if there's a clamp on, you need to undo it. If there's a tap turned, you need to turn the tap the right way. If the system's kinked over or trapped in the side of the bed, you need to alleviate that problem. But some of the things like clots or debris obstructions within the circuit, we won't be able to alleviate, and we will need to escalate to a neurosurgeon because as bedside clinicians, we don't access this circuit at all. We're going to complete a full set of neurological observations on the patient, and if you can't identify any of these things and it's still just not draining, what you're going to do is gradually lower it to the floor. As soon as you start to see drainage, or you can see CSF sort of gently swinging within the tubing with respiration, you know that your EVD is not blocked. Because if it was blocked, you would have no drainage and no swing at all. So you can be much more confident that it's not blocked. It's probably just tailing off. And yes, you want to let your neurosurgeon know, but it doesn't have to be that neurosurgical emergency where we expect them to attend within 30 minutes if we determine at the end of this troubleshooting that the EVD is blocked. So if you do lower it to the floor, the minute that it starts draining, just pop it back up again. But if it doesn't drain and you end up with your EVD pretty much on the floor, you know that it's blocked, you refer to your neurosurgeon, and in our hospital we expect with this guideline, and the neurosurgeons are aware that they should attend and resolve the situation within 30 minutes. Because otherwise we're leaving a child for half an hour with an inability to drain CSF, and therefore their ICP will significantly go up. Once that's done, you complete some blockage observations. Again, it's a documentation and audit tool to kind of say what we found, what we did, what's the neurological observations of this child, and this would get done every time an EVD is suspected of being blocked. So the EVD system itself, everybody will use a slightly different system, and it doesn't matter which system that you use, the principles are all the same. So hopefully you can see this, the patient. So the EVD catheter will obviously be inserted, and again, the first connection here is like a Luer lock connection, so you need to make sure that that's tight. And then there's always a tap at the end of the first catheter that comes out of the patient, and again, it's a two-way tap, like I said, on the entire system. So you always need to make sure that that tap is open and so that drainage can come out. And the most useful way is to always track back from the patient to your drainage bag and then back in the opposite direction. And if you can follow CSF flow through the whole system, you can be quite confident that that's open. This will then next flow into the CSF chamber. So from the patient, green, it will come up into the tap, flow through the chamber here and into the top of the chamber. Will drip down into the chamber where the nurses will document the volume that comes out each hour. And then once they've read that, so if it's 10 mils that hour, they will open the clamps and it will drain into the collection bag. And that collection bag will just fill up and it will only be emptied when it's full or if its integrity is lost. So that you don't need to worry about. This is the hang strap, and this is what enables you or the nurses to adjust the height of the EVD so that you can level it with the tragus of the ear. And we level with the tragus with where the ICP tap is. So this red bung here on the tap will be level with the tragus of the ear at all times, and that's the equivalent of the foramen magnum, which is almost the central to zero gravity part of the brain that the neurosurgeon decides the centimetre of water to be set at. And so you can see the black arrow, and not that this is our job to change it, because actually if the neurosurgeon's coming around to prescribe a change in the EVD level, they can do that themselves. But it's very simple to do, almost too simple, which is why if this isn't tight enough, you can see how this chamber can slip up and down quite easily. But essentially that black arrow will be levelled with whatever EVD level they've decided to set it at. So it's this tap here that's going to cause the most problems, and it really will cause a problem every hour when the nurse empties it into this chamber and if you have ICP on. So if you're monitoring ICP, the ICP transducer will sit onto this tap here. So at the minute, this CSF comes in and goes into the chamber, so it's open to drain. If you want to monitor ICP, this tap has to go off to drain so that the patient can read the pressure ICP. But if that's forgotten to be turned, it will never ever drain into that chamber. So you've got to remember to always keep it open to drain, which is why if the ICP is attached, we only do an intermittent ICP check, read it on the monitor, open it to drain once every 30 minutes. Quick check, turn it back off. The other times that will happen is when the nurses are draining from the chamber into this bag, They're taught obviously because they're going to unclamp to make sure that the system's clamped off. So what they will do is they will turn it off to the patient, undo these clamps so that it can drain into the bag, and put the clamps back on. And if they forget to turn this tap and reopen it to the patient, again, CSF flow will be impeded into this chamber. So the next hour you might find you've got a 0, but using a troubleshooting system that is the same every time and is documented in this nice clear approach will very quickly in the first few seconds tell you to check your taps, and you'll find that the tap is off and you can open it to drain. So the most important thing to remember about this system is that it's always open to drain, that if you get a 0 drainage or it doesn't drain, you should treat that as a neurosurgical emergency. And follow your troubleshooting process to encourage some CSF drainage. And when we talk about lowering the EVD to the floor, you're literally just going to take it off the drip stand, hold it where it is, and gradually lower it to the floor. And the minute that you start to see even just a drip dripping into this chamber, or swing in the tubing with respiration, you can be reassured that the EVD isn't blocked. It might be under draining. You still want it looked at, but it doesn't have to be that 30-minute arrival for a neurosurgical emergency. But if you do that and you get nothing, then you should absolutely expect them to come. It's really helped us in Birmingham to try and work with the neurosurgeons to establish this relationship with them. It can be tricky, and it depends what centre you work in and how much you use EVDs and what your demographic of your unit is like. So at Birmingham, our unit is incredibly junior in terms of nursing staff, and so they need really clear documents and policies to be able to follow, because we use this device so infrequently. And we have neurosurgeons that have worked in many different centres who don't really have a grounding on what expectations are when they work in a paediatric intensive care unit. Most of them have worked in adult units. And so they use EVDs a lot more, and therefore they're much used to using them, and they have a consistent practice because there's one adult intensive care unit, whereas in our hospital we have children managed with EVDs on the intensive care unit, on the neurosurgical ward, and on the neonatal ward. And because the practices initially were very different between areas, and the escalation of communication was really different, I think that's where we found some cracks in the system. And that although, for example, PICU were incredibly good at escalating, we didn't have any problems probably because we can escalate in a bit more of an empowered way to get the neurosurgeons to arrive in the right timing. That didn't always happen on the wards. And the risk is then, if the neurosurgeons don't hear the information that gets them to come and assess that patient, we potentially could be left with patients with a blocked EVD that's raising their ICP and therefore giving them a clinical deterioration, which is exactly what we want to avoid. So I hope that has been useful. It's a bit of a whistle-stop tour of the EVD system, but I hope that I've given you some food for thought and got you to remember that these are a high-risk device, that we do absolutely want to avoid an EVD that doesn't drain, and we want to keep these children safe at the bedside and get them to have a good neurological outcome. So any questions, more than happy for you to drop me an email or share anything that you want. Thanks very much.